Hello, everyone. I am Dr. Judith Cornelius, Vice Chair of the Academy's LGBTQ Health Expert Panel, and I want to welcome you to our policy dialogue on nursing's responsibility to our patients and our profession, countering the attacks on transgender and gender diverse health. As a reminder, we do have closed captioning available for this event and for the opening remarks. Just to give you a brief overview of the topic and a background of this topic, this policy dialogue will identify how recent policies are attacking transgender and gender diverse people's health, harming patients and communities, and affecting healthcare providers' ability to safely deliver care. Following presentations and a question and answer session from our guest speakers, we will briefly outline the major themes each speaker discussed. As a note, a recording of this policy dialogue will be released to all attendees who registered in the coming events. As you saw during registration, this is the purpose statement and learning outcomes for today's policy dialogue. The American Academy of Nursing is accredited as a provider of continuing nursing professional development. So if you purchase the 1.5 contact hours during registration, you will be awarded these after viewing today's event and completing the evaluation release afterwards. You will be emailed your certificate of completion within 2 weeks after completing the evaluation. We will start our presentation from our guest panelists, where you will hear from different solutions for this issue. We would then transition to the Q&A for 30 minutes, where you'll be able to have a live discussion led by our experts. Now, I would like to give you a brief bio of our presenters. Our first presenter is Ms. Paula Neira. Paula is with the Johns Hopkins Medical Program. She is Director of LGBTQ+ Equity and Education in the Office of Diversity, Inclusion, and Health Equity. As an attorney, Paula was a leader in the repeal of the Don't Ask, Don't Tell policy and in the change of military regulations that allow for transgender military service as part of her role at Johns Hopkins. She lectures nationally on the need for improved transgender cultural awareness and health equity. Our second speaker is Dr. Linda Wesp. Linda is an assistant professor at the University of Wisconsin-Milwaukee School of Nursing, where her program of nursing research and scholarship is focused on community-based participatory research with transgender and gender diverse people to address health inequities through collective action. Linda is a co-author of various publications and evidence-based guidelines for gender-affirming care, including most recently, the World Professional Association for Transgender Health Standards of Care, version 8. Our third speaker today is Ms. Dallas Ducar. Dallas is a visionary healthcare leader who's steering an organization committed to transforming healthcare. Dallas has helped advise local, regional, and national elected leaders in best practices and policies for gender-affirming healthcare, including advocating for professions for providers, and continues to push the needle of justice forward daily. Our fourth speaker today is Dr. Liam Hein. Liam is an associate professor at the University of South Carolina and is a nurse. Liam's work focuses on improving LGBTQ health equity through education, advocacy, activism, and health policy. Liam is currently interested in transgender elders amidst current state-level political efforts. Just a reminder, if you have a question or need assistance for staff, Please use the chat box at the bottom of your screen. Questions are welcome, and they will be discussed in the Q&A. Now we'll begin with our first speaker.
Thank you, Dr. Cornelius, and good morning, everybody, and welcome for joining us. As a nurse and an attorney, I'm going to try to set the high-level context and be able to share with you some of the social and political environment in which we're trying to provide care and provide medically necessary care to a population. In the United States, we tend to think of health as being the absence of disease, and really to take a more holistic look at all of the factors. We talk about the social determinants of health, all the factors that impact health, and to understand both to be more effective patient advocates and also to understand that we as nurses in the profession have to have an understanding of the environment that's directly impacting care. Now, when we specifically talk about gender affirming care, we're talking about care being provided to transgender and gender diverse people in a holistic manner. And this is care that is grounded in over 100 years of best practices and over 60 years of research and evidence-based medicine. This isn't a new phenomenon. It is not experimental. It is not just merely cosmetic. This is, for many people, life-saving care, and for everyone, life-altering care. The 50 years of research that this is based on has provided standards of care, whether it's the World Professional Association for Transgender Health version 8, which came out last fall, the Endocrine Society guidelines, which were established in 2017, the last update, the ICD-11, the international code, which was adopted outside the United States in January of 2022, which moves this whole issue into sexual health where it belongs, because being transgender or gender diverse is not a mental illness. And also our Diagnostic and Statistics Manual, which talks about gender dysphoria, that distress when your gender identity, your sense of yourself, doesn't align with your anatomy or how the world's interacting with you. And the other speakers are going to talk in much more detail about that. It's medically necessary and recognized as such by every major reputable American medical and healthcare association. The Academy of Nursing, American Nurses Association, the American Medical Association, the American Academy of Pediatrics, the Endocrine Society, the World Professional Association for Transgender Health. Those who are saying that this is not evidence-based care, this is not medically necessary, are relying on pseudoscience and relying on ideology that is not grounded in medicine or healthcare to support their positions. So when we talk about what's going on, particularly in the United States, is to understand that this is also a global phenomenon, whether it's in Russia, trying to pass laws attacking the LGBTQ plus community, whether it's in Poland, trying to establish LGBTQ free zones, whether it's language attacking the transgender community used by the Prime Minister of the United Kingdom, or whether it's here in North America, in the United States, and I'm going to talk a little bit more about what's going on here in the United States, but also realize that this is also happening up in Canada, where provinces such as New Brunswick or Saskatchewan are trying to limit access to medically necessary care. So here in the United States, there's been an exponential explosion of legislative attacks on the ability of people to access medically necessary care, access healthcare, to perpetuate barriers to care, to perpetuate health inequities. In March of 2021, no state had barred access for minors to gender affirming care. This year, 22 states now have legislation that was passed barring that kind of care. Over 725 pieces of legislation at the state and federal level were introduced, which were designed to either bar care bar access to facilities aligned with one's gender identity, bar the ability to update your government identification to reflect who you are, to reimpose bans on transgender people being able to serve in the military, to bar access to medically necessary care for veterans. All of this is currently being in the works. At the state level, 70 pieces of legislation aimed at reducing the ability of transgender, gender diverse people to access healthcare were passed. And all of these cases are now tied up in litigation, either at the state level or at the federal level. And the decision on whether or not this is a state issue or a federal issue really has to rely on the law in that jurisdiction as to which one provides the most protections. All of these cases, like I said, are being litigated, so there is no final decision. And we as nurses should understand that this process takes time. And whether or not you hear decisions made at the federal district level, the circuit court level, the reality is that eventually this whole issue is going to have to be decided by the United States Supreme Court, because there are differences in opinions of whether or not it's constitutionally allowable for a state to bar access to care for a certain population. And there's many similarities between the legal framework that was used talking about reproductive rights and banning abortion that are now being used in attempts to ban access to medical care. When we talk about some of the Supreme Court decisions, like the decision that said that you can't discriminate against transgender or gay people, and I'm using the words transgender and gay as umbrella terms for the LGBTQ plus community here, is that that's a form of sex discrimination. And things like the Affordable Care Act, Section 1557, is an anti-discrimination policy which says that you can't do that in healthcare. These are still issues that are being litigated and challenged. So you need to ask yourself, and nurses need to understand, is why is this happening? And it is really a toxic mix of religiosity and partisan politics that is leading to non-evidence-based, non-scientific-based policy. This is, implementing a very conscious agenda, and nurses should be aware of, the words that are being used by those who do not support transgender and gender diverse people being actually recognized in society, let alone being able to access their health care. It's, attempts to criminalize the provision of care, to penalize parents who are supportive of their children. You've seen that was, an attempt that was made by the state of Texas. Alabama, in passing their law, has created criminal penalties for healthcare providers who provide gender-affirming care. Whether or not this is defined as child abuse, such as it was in Texas, are attempts to try to incite fear in parents and in healthcare providers so that they withdraw from being able to support transgender and gender diverse kids. You're seeing attempts to bar access to facilities in school, to ban books, to ban the ability to speak about LGBTQ people in schools and in education. And even in the state of Missouri, their attorney general attempted to create their own standard of care for medicine without any input from the experts that actually do this type of care. It's an attempt to erase LGBTQ people from society, whether it's by denying them the ability to exist in social settings, updating driver's licenses, updating birth certificates, or whether or not it's being able to access care. All of this is designed to embed discrimination in the law and then to make structural changes that would make it harder than to overturn these once they're in place. And again, this is not something that is just a one-off. This is part of a designed agenda, and nurses need to be aware of it, because not only does it harm our patients, and most of us are going to interact with transgender patients for reasons other than gender affirming care, but this environment has a marked negative impact on health, by increasing in things like minority stress, increasing anxiety, increasing the potential for depression and mental health outcomes. All of these are inequities that we know already exist and are just being exacerbated. So for us as nurses, it's important for us to understand what the care is, and then again, the context in which it's being provided. And the other speakers are going to talk more in detail about gender affirming care, but I do hope that you now can understand that this is being delivered within an era of a high level of anxiety and uncertainty within our current social situation here in the United States. And with that, I'm going to turn it over to Dr. Linda Wesp.
Thanks, Paula. I'm going to spend some time talking about how, in particular, these attacks and these bills that have been passed that Paula outlined for us, how these attacks on transgender and gender diverse people's health are also a direct attack on evidence-based clinical practice. So I'm going to give us a little bit more of a deep dive into the clinical practice guidelines for gender affirming care, and then share just a smidge of some details about ongoing research, and particularly focused on youth, because so many of these bills are targeting minors. So the first guideline I want to highlight is the World Professional Association for Transgender Health Standards of Care, version 8, as Paula mentioned, was published last September. Paula and I were actually both had the opportunity to be co-authors, among many others. It was a large group of experts who were brought together. And we followed a rigorous process of developing clinical guidelines. So it took 3 years or so. The guidelines include 18 chapters covering different age groups, the recommendations for mental health assessments, medications, surgeries, et cetera. We went through systematic literature reviews, wrote up the chapters, wrote up recommendations, went through a Delphi process of consensus building, open for public comment, incorporated those comments. And this process really aligns with the way other specialty health organizations generate their expert standards of care. And one thing I want to point out is in Standards of Care version 8, there's distinct chapters for children and a distinct chapter for adolescents. The work we do in providing gender affirming care to youth, it really differs once someone has begun adolescence, and the way we consider that physiologically is a Tanner stage 2 of puberty. And so there are very clear, detailed guidance about what youth experiencing gender incongruence and gender dysphoria need in order to make sure that there's an expert interdisciplinary team working with them, completing biopsychosocial assessments, 8 very specific mandatory requirements that must be met before any gender affirming medication can be begun. And I think this is some of the misunderstanding and the media and all of that. It's important. I want to bring us back to what these standards of care say we are doing, and this is what we are doing as experts providing this care. And the other set of clinical guidelines I wanted to touch on is the Endocrine Society. As Paula mentioned, both WPATH and the Endocrine Society have been putting out these standards of care for decades. The Endocrine Society most recently updated their version in 2017, and it's one of their many clinical guidelines about providing endocrinological treatments, similar to their guidelines on thyroid conditions and diabetes, et cetera. And really what Endocrine Society's guidelines do as well is provide detailed recommendations about the assessment and management and prescribing of medications, GnRH analogs for puberty suppression, feminizing and masculinizing hormone therapies for both adolescents and adults. So these clinical guidelines are rigorous. They've been around for a very long time, and it is what we use as providers and practitioners. This is what we follow, similar to any other type of healthcare we would be providing to a unique, around a specialty population. Just like any clinical guideline, as soon as it's published, there's new research that keeps coming out. So I want to spend the rest of the time sort of touching on that a bit. Ongoing research really continues to inform and improve what we do and the care that we provide to trans and gender diverse people. Many of these bills and many of the sort of rhetoric discussion around banning gender affirming care, the argument is that we're lacking evidence. This is just simply not true. Many opponents also suggest that because we don't have randomized controlled trials, the gender affirming care lacks the right kind of evidence or robust evidence. And conducting a randomized controlled trial with youth, for example, would be unethical. We have a standard of care. We cannot withhold that standard of care from someone who's eligible for it. And so, you know, there's a misunderstanding, I think, generally, and then, you know, just an inappropriate suggestions about what's needed. There's a good sort of editorial discussion about this recently in the New England Journal of Medicine, you know, outlining the way that we're going to move the gender affirming care forward with research is really going to be among large longitudinal cohort studies. That's where our strongest evidence has come from. It will be continuing to be where this information comes from to help us provide this care. We've had cohort studies happening around the globe for decades, enrolling thousands of youth and adults. One important issue here in the U.S. is that research has not been funded. So at the same time, we're being criticized that there's not enough research and we need more research. It really hasn't been funded. Some of the original research programs in the 70s were defunded by the early 80s, and therefore research in the US has really remained scarce for most of the end of the 20th century and really up until you know, 10 or so years ago. In 2015, the NICHD did fund a multi-site R01 focused on trans youth. It's a longitudinal cohort study with trans youth, and this has been, you know, providing a lot of important information about the specific U.S. context and the specific challenges that youth in the United States are facing, and then the impact of gender affirming care. Just to note, they were funded in 2015 and then faced a 40% budget cut right after the 2016 election. And so the challenges of the funding do continue, but despite this, they have enrolled over 400 youth in this cohort, and they just presented some of their findings at the recent US based Professional Association for Transgender Health conference just a couple of weeks ago. So I wanted to just share a slice of that with the time I have left. And so in one of the studies was a baseline description of the youth presenting for care. Now this is a large multi-site, you know, center urban sites, Boston, Chicago, LA, San Francisco. So youth presenting to care in these spaces are youth who have parental support and who can get in to an academic medical center for care, right? And go through the rigorous process of assessments. And at baseline, prior to any gender affirming hormone therapy, these youth have very high rates of depression, anxiety compared to population-based norms. And particularly alarming is a 66% lifetime report of suicidal ideation, and 24.6% reported a previous suicide attempt. So these are a group of young people with significant psychosocial and mental health concerns. The same cohort published a follow-up paper in New England Journal of Medicine just earlier this year. And they again looked at the battery of sort of outcomes among youth who had then been prescribed gender affirming hormone therapy for at least 2 years. And particularly what's important, I think, about what they've done with these data is they're looking at how gender affirming hormones are improving psychosocial health. And what they're finding is that when youth have an increased appearance congruence, so a sense of one's identity is congruent with their appearance, this is what is improving psychosocial functioning, decreased depression, anxiety, increased positive affect, increased life satisfaction, and suicidal ideation at that point among youth who are on hormones for 2 years was 3.5%. So we know gender affirming hormone is making a difference. These data are supporting it. It is, of course, not the only factor. As nurses, we know that there are multiple factors. Family support is crucial. Social affirmation is also key to making sure that we can support, especially young people, in having improved quality of life. So our scientific foundation for gender affirming care, it is robust, it is growing. We know that gender affirming hormone therapy improves a variety of mental health outcomes. The data I shared today is among youth, but we have very similar information for adults as well. And then, so in states where these legislation have passed, right, as healthcare providers, we are threatened with losing our licenses for providing these interventions. Youth cannot access these medications in these states currently. And these are youth who were presenting with these alarming rates prior to being started on hormone therapy. The legislation that is preventing us as healthcare professionals from providing this evidence-based care really is undermining our obligation as nurses, ethically, our dedication to science and evidence-based care. And so I hope that folks can take some time to go to the data, go to the evidence-based guidelines, and really kind of get a sense about the work that we're doing and the evidence that is supporting it. All of the clinical guidelines are open access, provided for you, on the resource list. And hopefully this is helpful to give us a little bit of a sense of where we're at in the sort of state of the science. There's still plenty of nursing research that's needed, but we're in a bit of a crisis moment right now when it comes to really making sure that I think us as professionals and practitioners have the understanding of what already exists. So I'm going to turn over to Dallas now to take us into the next part.
Thank you so much, Linda. I really appreciate that. That scientific foundation is spot on. We know that this is good healthcare that we're providing. It is scientifically backed. And the key to actually providing life-saving care and the answer to there's not enough research is do more research, right? And unfortunately, we're seeing that stymied as well. I'm going to talk a little bit about the public sentiment versus public reality, breaking down some barriers too, and crafting a story of us, thinking about how we move forward here. I think we hear a lot about the landscape and we hear a lot about the foundations, and sometimes we're left with, well, what do we do next? And so my hope is to really provide some understanding of where we go from here. Number one, when we look at the public sentiment and policy reality, we have to examine our roles as nurses, right? Our role extends to advocacy, and really it's critical in bridging the gap between public sentiment and legislative action. We as nurses are the most trusted workforce. This has been true ever since 2001, when firefighters were briefly the most trusted for obvious reasons. And so nurses really play a central role in being able to bridge that gap. And what we're seeing are politicians from Florida to Idaho are attempting to turn trans rights into a divisive national issue. But in my experience as a trans woman who's lived across the country, these positions really seem out of touch. The various conversations that I've had with conservative neighbors in Arizona or centrists in Virginia are not that different to the ones that I have now living in Massachusetts. The vast majority of Americans really do believe in liberty and don't think it's their business to be regulating the identity of others. And what we've seen is these attacks on trans people create headlines, but really Americans have a very different priority and approach. And I believe that this has backfired and will continue to backfire. When we look at voters' real priorities, those are generally the economy and healthcare, as they often are. And this is according to a most recent Pew survey. Another poll by the AP shows that the top priorities for more conservative voters are inflation, gas, food prices, energy. And for more liberal voters, it's healthcare, climate change, poverty, racism, and reproductive justice. And we see that trans rights really don't make the top 20 of this list, this priority list. And let alone the warped allegation that trans people have too many rights. When you really narrow down the question to Americans' attitudes on gender, we find that nearly 8 in 10 Americans support non-discrimination. A 2021 poll found that 2/3 of Americans oppose bills limiting trans rights. A Fox News poll that came out a couple months ago showed that 83% of Fox News respondents believe that trans children are wrongly targeted by political attacks. So this is what the majority of people say, right? Which is just disconnected from the politics here. And this really follows big picture trends like a decades-long evolution that led to the legalization of same-sex marriage in 2014, or the trend among next generation voters, where we see 5% of youth now identify as gender diverse, 3 times the rate in the greater population, because we're seeing more acceptance of gender diversity in general. Unfortunately, this is really a manufactured and marginal issue. And since 2020, as we've heard from Paula, we've seen widespread state laws restricting trans kids from participating in sports, limiting access to care, banning the mention of LGBTQ history or individuals in school. So as nurses, we can follow our code of ethics and instinctively advocate for patients in the workplaces and communities, but also in legislative and political spaces too. We are the most trusted profession, and we can utilize that trust to speak to others about the importance of evidence-based care and also get involved in legislative action. We can be catalysts for change. But then you might say, well, Dallas, how do we actually have these conversations? How do we speak to those that we might disagree with? Well, there are 4 barriers that a lot of different political scientists have found that are impeding trans rights support and affecting healthcare delivery. Really, these 4 barriers go into trans people aren't like me, so I'm not sure I want to support them. Trans people are a threat to society, so if I support them, bad things may happen. Trans people don't need more rights, I'm not sure they need more support. Or if trans people get more rights, I will have fewer rights myself. So what we can do here is start to have conversations, right, and dispel this information. Engaging in the movable middle, right? Not engaging in those people that are far off on a spectrum that will never agree with you, but instead the people in the middle of a large population who just really haven't ever known that they've met a transgender person. Maybe they have, but maybe they don't know. And presenting them with frames, images, people that resonate, speaking to journey stories and conversations that can move the movable middle, such as, it can be hard to understand what it's like to be trans, especially if you have never met a trans person or don't know you have. I get it. I've been working with trans patients, or I have trans friends for, XYZ, and this is what I've learned. And starting there to help really dispel narratives. Additionally, we as nurses can also work to ensure that our clinical practice at all times just has what I would call universal precautions, that we're always using the right name and right pronoun by starting by introducing ourselves, having it on our badges, introducing ourselves when we talk to every patient with our own name and pronouns, and then asking the patient for theirs. And that just opens up a window to conversation. There's many, many, many more things we can do outside of just talking about pronouns, but it is a starting point, something that you can carry away with you right now. You can also learn more about journey stories and talk to those stories. And when talking to people who otherwise are impacted by those 4 barriers, to talk about the narratives that you've learned from friends or from family or whoever else. Also, a third point here is when talking to anyone who may not have met a trans person or, maybe in that movable middle group, drawing on the work of Marshall Gantz, who's a great organizer. He is really credited with the idea of creating a story of self, a story of us, and a story of now. Who are we? Who's our shared us? And what are we responding to now? So a shared identity in who we are. Who are we to each other? To see the challenges shared, to be able to reach a shared choice and outcome, it requires a shared understanding of who we are. So we need to tap into a shared sense of values, right? We need to reflect on what we're trying to connect on, what the common ground is, and being intentional, observant in the moment when having these conversations. And so what we found, or what many, at least, of people who do this polling has found, is that when you're advocating for a shared story of us, basing it off of shared values, right? When we think about what was instrumental in helping people get vaccinated for COVID, for example, it wasn't data and science, it was showing the shared values and what people care about together. So here too, it's showcasing our shared values of freedom, of liberty, and the pursuit of happiness. And these words are specifically poll tested to counter divisive legislation, because at the core of our democratic values lies a promise of liberty, of freedom, and the pursuit of happiness, and a pledge that really should extend to all, including trans individuals. And the ability for trans individuals to direct their own care is not just a health issue, but a testament to these foundational rights. It speaks to the essence of parental rights too, as we've heard in some elections, and the sanctity of a family unit that should be free from government intervention. So when we acknowledge that these are complex issues, it's acknowledging the freedom of that person to be, the freedom of parents to make the best informed choices for their children without the government banning healthcare, and to get to better know their child too. As a country, at least in the United States and many other democratic countries, we can pride ourselves on a celebration of individuality and the freedom to express who we are. And that expression extends to our health, our personal decisions, and it should be made with the protective embrace of family, not restrictive bans posed on bodies. So when trans people are supported and free to make their own healthcare decisions, they thrive, contribute vibrantly and significantly to society. And recognizing and respecting that is critical to strengthening a larger fabric. But that only happens when we acknowledge our shared us, when we acknowledge our shared story, when we pinpoint the values that we share with others, which allow us to unite and to move forward. And so really, when thinking about where we go from here, really the point of this is to have conversations who might not always agree with you. And when advocating for change, utilizing your role as an informed healthcare professional, as a nurse, to be able to bridge those divides by creating trust, by following the code of ethics and advocating for patients, to dispel those 4 barriers and to dispel misinformation, which can turn into legislation and violence, and instead craft a shared story of us, of who we are, of who we are as nurses, and of who we are in a democratic society and what we stand for. And so I just want to close here by having everyone to just think about one thing that they will commit to when leaving this talk today. One thing that you can do, one of these actionable items that you can do, whether it's talking to someone, whether it's specifically targeting and dispelling misinformation, whether it's acknowledging shared values, but something that you could do, even if it's just putting pronouns into your conversation, that you can commit to when you leave here today. So thank you, and I'll hand it over to Liam now.
I love what Dallas just said there, and it really comes down to what kind of world do we want to live in? Our code of ethics, as she noted, identifies a lot of our values, who we say we are as nurses. And I think that's really what we need to ground ourselves in. Who do we want to be as a profession? Do we want to continue to be allies, advocates? And I think we also need to think about that we don't forget anybody in that process. The other presenters have spoken about youth and transitioning and the WPATH guidelines for that, as well as for teens. But another group that concerns me is the elderly. Particularly in some of those states that are very restrictive at this. Paula alluded to this earlier. Well, more than alluded to it, talked about it in specifics, but issues like in Florida, for example, where nurse practitioners are no longer permitted to write for hormones for trans care. And that was the primary source for everyone, children and adults, to receive their hormones. And I personally have found that individuals associated with health insurance or even male pharmacy groups have taken it upon themselves to decline filling rightfully submitted prescriptions. And of course, there's no recourse because it's to those same people that you're appealing. So I would challenge you, you need to decide where you stand. Are you an ally, And I think we often get these confused as nurses, allies, advocates, and activists. We often say, well, we're an ally to the community. And that is basically you're standing beside. And as a nurse, yes, that is probably the absolute minimum that would be acceptable. But we also say we're advocates as nurses. And that's really arguing on behalf of things or bringing attention to an injustice experienced by a group or organization. And I would argue that that's our moral duty as nurses. But I think we actually need to more identify as activists and advocates. And I know that kind of raises some people's eyes when you say activist. But really, what an activist does is they change the system. And that is our social ethics duty. It's acting on behalf of solving social and political issues. And if you think about it, that's exactly what Flo did, and Lillian Walt did, and Harriet Tubman, a nurse, did. That's actually all of our history. And we've kind of set that a little bit aside. And I would argue we need to re-embrace that, not only just as individuals, but our professional organizations need to do that as well. And when we think of what have we done as advocacy in our professional organizations, well, that would be our position statements, our policy statements, our affirmation of evidence-based guidelines. And that is needed. Absolutely, that's needed. And we could even take it to a particular form of advocacy in our lobbying, that we have lobbyists for our professional organizations. Again, very essential. But where can we take that next step to activism? And I would say we do some of that very well. And we sign on to amicus briefs, friend of the court briefs, for whether that be a circuit court or whether that's for SCOTUS. And I would ask, and I would challenge our professional organizations to also co-sponsor lawsuits that are happening in all of these states, many of these states. And that may be, for instance, healthcare restrictions have passed in 19 states, and there are challenges in court in 9 of those states. Has the Academy, has the ANA signed on to those cases? Are they demonstrating that, yes, as professions, as nursing's voice, this is inappropriate? We are not okay with this. And I would challenge us to do that. And I would also like to add that it is a little bit more severe, in my personal opinion, than you may understand it to be, what's going on, because you do have bathroom bans. You also, which, affects everyday life. And some states have actually tried to start collecting names of transgender people. Let that sink in for a second. In Florida, records were requested from 12 universities, 6 handed them over, of students who had received trans care that they knew of. Missouri tried to do the same, created a website which has since been removed, and Tennessee has taken records from the Vanderbilt Strands Clinic, their attorney general, patient documents by name. You are here because you care. You would not be spending your afternoon listening to us talk about this. I speak from a place of anger and fear. And those can both be used to help change things. And that's how I'm choosing to navigate those feelings. But it's a scary time. And it's a scary time for our elders who've gone through this before and are now in a more vulnerable place. And I would ask you, please, especially reach out to those folks that you may know, the kids and the elders. Thank you very much. I want to pop this on back to our moderator, Judith.
Hi, now we'll the next part, and that will be our Q&A.
Hello, everyone. I'm Dr. Elizabeth Saywick, and I'll be serving as the moderator for the question and answer session. You have a couple different ways to actually pose your questions. To ask a question, please click on the Q&A field at the bottom of your screen so you can type in the question for the speakers. You may also type your comments into the chat feature, and if they're questions, we'll move them into the Q&A. I see we've got questions beginning, and now I'll start with a first question to kind of get us started with Paula. What do you foresee for the upcoming 2024 legislative sessions in terms of proposed legislation aimed at harming the health of trans and gender expansive people?
I think what we're going to see over the next 12 months, because it is also a presidential election and the political stakes are so high, and because in a partisan fashion, folks think that attacking transgender people will help, even though that wasn't reflected in the 2023 off-year elections. I think you're going to see that high level of bills introduced that are going to, again, impact transgender health stay at that high level. When states where they were unsuccessful, they're going to try again. In states that had some success, they're going to take the next step, where if they've been able to ban care for minors, they're now going to go after adult care. So I think it's going to be a very fraught 12 months. And it's going to be imperative on nurses to make sure that we're providing the facts, that we're countering misinformation, and that we're engaged citizens and involved in the process.
Thanks. Linda, what sort of information is available to guide specific nursing interventions and the role of nurses in general related to gender-affirming hormone therapy or gender-affirming surgical care?
Yeah, I think there are some things that exist. For example, the National Organization of Nurse Practitioner Faculty have put together an entire toolkit for nurse practitioners. So for advanced practice nurses who may be prescribing hormones, or maybe working and providing primary care for folks who are taking hormone therapy of all ages. So there are some tools that exist. I think at the very basics, it's important to look to, there's plenty of resources out there about, as Dallas kind of talked about, the very basic how to provide culturally safe care, making sure we're using affirming names and pronouns with all of our patients, no matter where we are. And I really think that there's continues to be more we can do to consolidate places where we provide these types of toolkits all the way through, from registered nurses up through nurse practitioner education and preparing PhD prepared nurse scientists to really be thinking about how to be accurate in doing providing tools to our profession.
Thanks, Linda. Dallas, back to you. Can you, what's one proactive step that nurses can take to ensure good healthcare for trans and gender diverse patients?
Yeah, I think going back to that idea of universal precautions, I think that very basic element of ensuring that you have your own pronouns on your own badge with some type of icon that shows that you are there to support, but then also doing that research too, doing that work to be able to understand how best to support, and also making sure that in that work too, you have support resources too, because as a nurse, there have been countless times where then when I start that conversation, I have to be ready to then also engage someone who is trans or queer or whomever, in helping them to understand the support that they have and also to be able to get them the resources that they need and advocate for them. But it starts by being willing to actually open up that dialogue and show that you are someone who's done that work. So that's really the starting point, I would say, and it could directly have an impact on your patients and the care that you provide.
Great. And Liam, if you could ask for just one point of nursing activism for trans people from the audience today, what would that be?
As
Oh, you've just been muted.
I'm sorry. As individuals, keep learning, stand beside not only your patients, but your colleagues. When something comes up, I see a question in the Q&A about somebody's colleague who was basically run out of academia for teaching about trans issues. That can't happen unless they're standing alone. Stand with them. Please.
Thanks. So among the various questions I see, a first one, and this is for any of our panelists, transphobia often lies at the intersections of other oppressions, racism, ableism, misogyny, etc. Can you speak to policy efforts to attend to the intersectional impacts of these attacks, like asylum for trans refugees or assaults on trans people of color, eugenics in some of those triage algorithms? Any thoughts?
Yeah, I think that intersectional lens is the only way to look at this, because no one is just transgender or gender diverse. There's all kinds of dimensions. And when we talk about policy, when I was mentioning about building the structures into the system that then prevent you from changing it, that's things like gerrymandering. That's things like voter suppression. That's exactly what that goes to. And countering those efforts, because the impacts that we talk about within the transgender gender community is that then when we talk about transgender and gender diverse people of color who have other dimensions like disability, like nationality or ethnicity, whatever is bad, it's markedly worse. And it has to be all addressed together. It can't be addressed as a one-off. And it's especially talking about things like triage algorithms. It's that continual work to get the people that are involved in building those systems to understand that impact. And that's a heavy lift.
Dallas.
I just also want to flag that there was a recent U.S. Court of Appeals ruling. It was a Fourth Circuit victory, and it was advocating for the inclusion of trans people under the Americans with Disabilities Act. And what was really important about that work was that there, in general, are people that are inside and outside of the trans community that might be familiar with the purpose and structure of disability civil rights protections. And fortunately, that's changing. And there's been a lot of public education to explain that the framework of disability civil rights, unlike other laws, presumes that people with stigmatized conditions can function, or identities can function equivalent to others, but are not harmed by the conditions, but by social and cultural barriers. So in essence, there's not something wrong with the individual based on identity or their condition, but instead based on the way that society is arranged that creates intentional barriers. So the goal with this case in particular was to remove the barriers, not fix those held back by them. And that framework tracks really well with this intersectional lens too. And for that reason, I think it's critical to think just from a perspective of what are the barriers that are in place that prevent people from accessing what they need, not what is it about that person necessarily. And how do those barriers get layered on when the intersections of marginalization and minoritization occur? And I think that's why an intersectional lens can be so valuable here.
Yeah, that's a really important point. Thanks. I see a few different questions in the Q&A about countering the mis or disinformation related to detransition. And I know that we've certainly seen in a lot of social media a small number, it seems to be the same small number of young people who are the stories about those who transitioned and then detransitioned. They don't usually talk about retransitioned, but you know, just thinking, perhaps Linda, can you speak to the information about detransition or ways to counter some of that misinformation?
Sure. Yeah. I think the lens I like to take with this is that no matter what, I want to understand the patient in front of me. As nurses, we want to listen to the patient-centered experience of the person in front of us and support them, right? And so what's the trick, the problem with these detransition narratives that are in the media are that that a mistake was made or that harm was done. And really what we're talking about with someone who may choose to go on gender affirming hormones and then choose to stop gender affirming hormones, pause. There's a host of reasons why that might happen. And there isn't just one single story. And we know this as nurses working with patients. You can't just put a cookie cutter thing on every single person, right? And so so the numbers are small in the data, but I think really this is where I come to it from more of a what type of knowledge do we really value? And the important thing I think for us as nurses to understand, in a way we can sort of counter some of that very loud narrative, is to really understand and respect that people may choose to start hormone therapy, pause hormone therapy, stop hormone therapy, restart it for a whole host of reasons. And that is something that is valuable and something for us to listen to and continue to provide, you know, our best evidence-based expert support of that person and not abandon them. Yeah, so that's one of the things I would say.
Paula.
Yeah.
Oh, still muted.
Okay, can you hear me now?
Yeah.
Yeah. From a legal aspect, is to understand too that
The volume has gone down again suddenly. You're not muted, but
how about now?
yeah.
Yeah. I was going to say from that legal perspective is these cases that you're hearing, like you mentioned, it's a small number. It is a small number of people, and the ones that are most vocal is a small number of people that have been, you know, recruited by anti-LGBTQ, anti-transgender hate groups, several of which are legal assistance type organizations, to bring these types of cases alleging medical negligence to really not so much win, because their arguments really are not grounded in the evidence, but to create the fear of future litigation so that practitioners self-censor themselves and don't want to do this kind of work and don't want to get involved in this kind of work because they're feared that they're going to get sued. And you see legislative attempts to change like the statute of limitations so that someone much later on could sue if you provided transition related service to them when they were an adolescent or a young adult.
Thanks. Dallas.
I just also want to mention that there's one transition is a very individualized, age appropriate process, like Linda said, but there's one commonality, and that is the rate of regret is incredibly low, and it's lower than knee replacements. It doesn't mean that you don't listen to people who might retransition, as I call it, right? Every story is valid in its own right, but the rate of regret is incredibly, incredibly low. And where we see a majority of surgeries happen, it's not any children. It is cisgender kids, actually, who are receiving things like breast augmentation, not transgender kids. And yet there's no scrutiny there. And so it's just worth questioning why that might be.
Thanks. One of the other questions that has been asked is, what can the AAN do to support nurses and nursing organizations that are also under attack for supporting evidence-based LGBTQ and trans care?
I would argue a coalition. There have been many times in the past where the Academy has signed on to, like I mentioned before, amicus briefs with other organizations. Commonly will address LGBTQ issues with GLAM, who will sign on to amicus briefs. Do that with other organizations. So say NOP is attacked for increasing LGBTQ curricular standards. Stand with that. Stand beside them. Sign on to those briefs. Yes, they've kind of got their own lane in terms of education, but support them. I think that makes a big difference. If all nursing organizations had a united voice on that, who's going to stand against them?
There is a question thinking, oh, sorry, Linda first.
Yeah, just also real quickly, I mean, I think that there's a lot of us out in the world providing gender affirming care whose licenses are directly under attack. Nurses do not feel supported right now by our profession. And so there needs to be something, and I know someone put a comment, our state level nurse associations doing anything, our national level. I mean, there's more direct, specific support that is needed for the people who are pediatric nurses in endocrinology clinics, surgical nurses, nurse practitioners prescribing gender affirming hormones. They are our colleagues and they feel alone right now. And so anything we can do to create that support is really desperately needed.
And it's interesting thinking about as Paula mentioned at the beginning, that what's happening in the US here is actually part of a broader movement, and where other places are taking a page out of the playbook. As I'm from the University of British Columbia in Canada, in Vancouver, we actually see some of those same kinds of strategies being taken up. Lawsuits against clinics and clinical providers, as Paula had mentioned, policies in schools that are being passed by state the legislative assemblies in the provinces. One of the things that I noticed, though, that is a little bit different is that at least in Canada, we are seeing the reverse as well. That is, patients and providers complaining about the folks who are advocating hate and are identifying as nurses. So it is important that we as providers and as professional associations also remember that those who are not adhering to our professional code of ethics may also be someone we can complain about. There's a question about youth, that historically of children and adolescents kicked out of their homes for being LGBTQIA+, gender non-conforming youth are more likely to be kicked out or mistreated. And since 2021, there's just a question about whether there's been an increase in gender diverse youth who've been kicked out of their homes, in addition to knowing that overall anti-trans violence. I don't know if I can, if anyone here on the panel has data about that for youth in the US. I can tell you that in British Columbia, where I live, we've just launched our most recent survey of homeless and street involved youth in 38 different communities across the province. And we are seeing an uptick in the number of trans and non-binary young people who are out of home, and are out of home because they're kicked out, not just running away. Dallas?
Yeah, we know that at least from data from the Trevor Project in the United States, that overall 28% of LGBTQ youth reported experiencing housing instability or houselessness at some point in their lives. And they were at higher rates from trans or non-binary or gender diverse youth, including around 38% of trans girls, 39% of trans boys, and 35% of non-binary youth, compared to 23% of cisgender LGBTQ youth. So the rates are definitely higher. And what we are seeing is writ large, more acceptance of trans identities than what we've seen before in this country, which does also mean that there's more kids that are feeling comfortable to come out. And with that also means that there's more families that might also, unfortunately, then be contributing to that houselessness or housing instability due to lack of acceptance.
I see some questions about publishing formal recommendations around education and nursing research and practice related to promote trans health. And I'm wondering as well that advocacy for change, what strategies have any of you found successful to actually advocate for change in hospital systems or in the broader healthcare systems? Paula, we can't hear you.
How about now? I mean,
Okay.
can you hear me now?
Yes.
Yeah.
Oh, and now we can't.
Within healthcare systems, you have to, you have to have the support of your leadership, is because the willingness to invest time, resource, money is imperative. And you can make change within the health system if that's in place, because cultural awareness is generally low, and then the programs themselves require some dedicated effort. But with that alliance of the actual staff wanting to do it, and then the leadership, you can make those type of changes. More broadly, it's the continued advocacy. And just to that point about, right now, there is no mandate from the Joint Commission specifically about transgender and gender expansive health. There's nothing in the NCLEX that is specifically about transgender and gender expansive health. And until the accrediting bodies require it, there's always going to be an out for organizations not to make it a priority. If you make it a central priority, then there's going to be more emphasis on it.
In education, we teach to the test. And I remember a number of years ago when we noted that the NCLEX didn't have any content about adolescence, and a focus on including adolescents in the content on the NCLEX actually changed some of what was taught in nursing schools, which again ends up influencing practice as well. Thinking about the questions, there is a question in about the other countries beyond Canada where there are some changes in their access around gender affirming care, or a push for more research related to gender affirming care. And I know that the people are frequently raised the UK and Finland and Sweden as some of those places. Among this group, would you see these shifts in access to care or the type of care provided for youth as politically driven as they seem to be in the US?
In a word, yes. Efforts are being funded by
Can you repeat again?
And I said, these efforts are being funded by some of the same people that are funding the attacks in the United States. So, well, there's always a need for more research. That's the answer to what we do, is that, these are not, these calls in Europe are being misrepresented as being, well, see, they're regressing, they're banning us. No, they're saying that there needs to be a process for evaluation of the effectiveness of care. They're not calling for outright bans. But yes, is that these issues in Europe are not unrelated to what's going on in the United States.
I think one of the challenges that we see is the effectiveness and pervasiveness of misinformation, and the funders of that, because there are folks who are presenting what's going on in Europe as very different. If you actually read the decisions and the rationale for some of what they're doing, it's actually not eliminating care. It's improving the research, or it's diversifying, spreading the care more widely. So it is interesting to see how the messaging, especially in media, can sometimes shift our understanding of it, because we're not reading the detailed things. Dallas?
Yeah, and I would just say that the one thing we do know time and time again from the research is that access to care saves lives, and that there's not enough access to care. And so when these 2 points get conflated, access to care and doing more research, and therefore that slows down the access to care, that then can result in people's lives being lost. And I think in the United States, we've been talking a bit more about value-based healthcare. And in my mind, that is treating the right patient with the right treatment at the right time. And if we don't do that, that allows the comorbidities to continue on. That patient does not actually get access to care. It doesn't stop what they're dealing with by any means, because they didn't get treatment. And then maybe eventually they're seen in urgent care or emergent care because they didn't have trust in the healthcare system, right? So if we want to actually practice what we're talking about and put some resources behind value-based care, and I think this goes back to changing institutional policy too. There's a good, not only economic argument in terms of saving us as a healthcare system resources, but treating the right patient at the right time. That goes to then providing the access to care that people need. And when we conflate these issues, then it really threatens that access, which is just the core thing that we know that so many need across the country. Doesn't mean getting people into care and getting them a treatment day one, whatever that may be, but it's just ensuring they have a space to begin to even start talking about their own gender identity and be able to trust the healthcare system when discrimination rates are so high.
So one of the other questions that's asked is, what research is needed? What additional research? And of course, that could take us for the rest of the time. But if you could think about what are some of those key questions that we really need additional research on to support the wider public understanding, or to improve our practice guidelines and increase their awareness. Thoughts?
I guess I would say there are certain things that we know, like Dallas was just saying. We don't need more research to know that access to care helps people be healthier and have improved quality of life. I mean, we need to know how to, and I don't even think we also really. I think we need to shift towards, okay, here's an educational intervention that we can provide in baccalaureate nursing programs, in nurse practitioner, and then what is it exactly that we need to be doing to make sure that we support people to actually do what we're teaching them to do within the systems, help them learn how to do that within a system that is threatening, in various ways. You can't put the pronouns in the person's chart, and there's not, these structural things aren't there. So how do we really show that what we're doing is going to improve interactions with patients? I also think that as nurses, we have so much wisdom from other specialties about how we can support people navigating the everyday self-management of gender affirming, care. Medications maybe need to be injected on a regular basis, taken daily, navigating pharmacies, navigating social determinants of health. I think as nurses, we are the experts in this, and there's so much we can do that will help people who do have this access to care, which we don't need proof that we need, to continue to do that in a way that really supports people to thrive in a patient-centered, individualized way. And listening to the community, listening to our patients. That's the type of research that I get excited about. I think in the trans health world, there's really amazing work being done in the, with psychologists and, data-driven pathways about how this is impacting. But as nurses, what we can do is really help people navigate this. That's what we're experts at, and that's what we can do more of in our research.
Great, thanks, Linda. Someone's asked, would you recommend resources that would help support us in opening and continuing those dialogues with those in the middle who are uncomfortable and are struggling with gender fluidity or gender transition? How do we have those conversations?
I would say that there are some really good organizations that are dedicated to this work. GLAAD, the AA GLAAD, has some YouTube videos on how to talk to individuals in the movable middle, and specifically how to talk about messages that could then change the needle on cultural stories. There's also, I believe, communication toolkits from organizations like GLISTEN, or one great one is the Movement Advancement Project, also called MAP too, who does a lot of this analysis. And all three of those organizations do have different toolkits and different videos on how best to talk to folks. I would just go back to, there's not going to be one recipe to talk to everyone. Everyone's different, but just remembering that sharing personal stories or sharing the fact that I'm an openly trans person. There are other openly trans people in the world who are also thriving, and sharing those narratives is really helpful. So it doesn't then help the person to concoct an idea, and sharing that journey story, and then also separately identifying those shared values and speaking to those values, right? Okay, we both like the ability to choose our own healthcare without people telling us we can't get our healthcare. Let's start there, right? Let's not really even talk about the trans people at first. Let's just start with the value, and that would be my recommendation.
I think we've got like 2 more minutes. Any last responses in terms of resources? I know we also do have on the website for this dialogue, there is a variety of resources that have been shared. Linda.
Yeah, just real quick to piggyback on what Dallas said, as I think for those who are maybe there's implicit bias that exists, right? And so for those who are not of trans experience and want to be allies and activists, and want to bring this work, there's work that we do need to do to make sure that we're checking our own implicit bias, that we're checking the sort of normativity that is throughout our healthcare system and our society. So I would encourage people to look into, there's plenty of resources for that as well. The National LGBTQ Education Center has some great tools for working on implicit bias. Well-intentioned doesn't always necessarily mean a positive impact. So we want to make sure we're doing some of that work as well.
Great. Thank you. Thank you all for your questions. This concludes the question and answer session, and I'm now going to turn it over to Dr. Jeff Day. He'll be reviewing the major themes and key takeaways that each speaker discussed.
Thank you so much. My name is Jeff Day, as was mentioned. My pronouns are he and him. I am a primary care nurse practitioner who specializes in LGBTQ plus healthcare. And I was asked to just review some of the salient points of the discussion today of our dialogue. They include care of Liam, that trans people are legally vulnerable, and that trans youth and people of color are at heightened risk of discrimination and violence. And of course, you mentioned also the elderly population. Pointed out that trans people need allies, advocates, and nurse activists, and that activism is a hallmark of historical nursing. And you name-checked Flo, Lillian, and Harriet. Just to rewind to Paula's presentation, she stated that gender-affirming care is medically necessary, evidence-based healthcare, and is recognized as such by over 50 years of scientific evidence and every major reputable health profession organization across disciplines. The legislative attacks on transgender and gender-expansive health have increased exponentially in the past 2 years, and the current political environment is such that it is foreseeable to expect increased attacks and demagoguery against LGBTQ plus people in the upcoming year. In fact, 501 anti-LGBTQ bills in the United States were in the 2023 legislative session, and 84 anti-LGBTQ plus bills are now law, and healthcare is being restricted in 19 states. These attacks are part of a conscious plan to remove LGBTQ plus people from public life, and championed by far-right conservative organizations and an LGBTQ plus hate groups. This is analogous to the reproductive rights issue. It is rooted in the toxic mix of religiosity, white supremacy, and partisan politics. Linda directed us towards some clinical practice guidelines and pointed out that these guidelines to gender-affirming care and gender diverse people have been developed through a rigorous process of consolidating evidence and expert consensus similar to other clinical specialties. Because of the evidence we do have about the impact of gender-affirming care on improving mental health outcomes among transgender and gender diverse youth, randomized controlled clinical trials withholding this care would be unethical. Large multi-site cohort trials continue to produce robust evidence to guide our care. And then finally, we had some calls to action by Ms. Ducar. They included encouraging nurses to remain informed and leverage their credibility to influence policies that align with the needs and wants of the public and patients. 2, advocate for the adoption of universal precautions like the usage of correct pronouns and names to directly challenge these barriers within healthcare. 3, urge active participation and advocacy from state equality initiatives to op-eds and legislative hearings to wield our collective influence for change. And then finally, promote the crafting of a story of us that focuses on shared values such as freedom, liberty, and the pursuit of happiness to unify efforts against divisive legislation or practices. And I'll turn it over to Judy, who will wrap things up for us. Thank you.
Thank you, Dr. Day. And I want to thank our guest speakers for providing their expertise today. Thank you to the registered attendees who were able to join us for this important discussion, and not only join us, but to provide valuable comments in the chat, letting us know what special issues are going to be published on this topic. We also, all of today's discussion and policy recommendations will be put together, and a policy dialogue proceedings report will be released by the Academy. As a reminder, a recording of the policy dialogue will be released in the coming weeks, and if you purchase the 1.5 contact hours during registration, You will be awarded these after viewing today's event and completing the evaluation released afterwards. Again, thank you to our guest speakers, planning committee, and our Academy staff. Thank you for attending the Nursing's Responsibility to Our Patients and Our Profession, Countering the Tax on Transgender and Gender Diverse Health Policy Dialogue. Thank you.